Hello, everybody, and welcome. This is a continued conversation about health equity with an incredible panel of equity innovators. My name is Aysha Pamukcu. I will be moderating the panel, and I am a senior staff attorney at ChangeLab Solutions. I come to the world of health equity through a background in human rights and civil rights, so I'm really looking forward to this conversation. For those of you who are just joining us, welcome. This is a panel that is part of the Building Healthy, Equitable Communities. It's our new series that we have just rolled out this month, and it's a virtual space where you and we can explore the elements of a just community and the conditions that we need to make sure that all our children and all our families get to thrive. So over the next 6 months, we'll be releasing 6 collaborative episodes that will offer training and discussion on how policy plus community power can advance health equity. So on your screen here, you see the full schedule, and it's also available on our series homepage. Each episode is made up of 3 components. The first is a Medium article about laws and policies that are not taking health equity into account, and it gives some ideas of how we can respond. In episode 1, which is this episode, we looked at 10 local laws that might seem like good ideas, but in fact can actually be surprisingly harmful. The second component is a webinar that provides on-the-ground stories and innovations from community health leaders, as well as resources to support your work in healthy change-making. So Tuesday's webinar earlier this week covered the intersection between policy and health equity. And then we close each episode by moderating an expert panel. These equity innovators are going to be in conversation with each other, and they're also going to be responding to questions that have been posed by you. So that is what we are here for today. So with that, let's just quickly touch on format. Questions I'm going to pose to our panel have actually mostly been generated by you all, the series participants. So if you think about questions as we move along or something sparks a thought, please do feel free to type them into the chat box. You see it on the bottom left corner of your screen. And if you don't see your question answered today, it's likely that it's actually a better fit for one of our future episodes. And they're going to cover more subject matter specific ground, so schools, food, the built environment, and the like. So with that, I am going to turn it over to our speakers, allow them to introduce themselves and their organizations, and then we will move straight into conversation. So let's go ahead and have folks introduce themselves in order of their photos so people can place a face to the name. And we'll start off with Jonathan, then Mary, then Sarah. All right, passing the mic to you, Jonathan.
Great. Thank you so much for having us be part of this. We're excited to be part of it. So I am Jonathan Heller. I'm one of the co-founders and one of the co-directors at Human Impact Partners. We're a nonprofit that's based in Oakland, but we work nationally. Our mission is to transform the policies and places people need to live healthy lives by increasing the consideration of health and equity in decision-making. And the way we do our work is through research and advocacy and capacity building, and we think of ourselves as trying to bring the power of public health to campaigns and movements for a just society. So let me just go quickly into the research, advocacy, and capacity building components. So we do a lot of policy-focused and participatory research that evaluates the health impacts of policies across a range of issues, including criminal justice, economic security, immigration, housing, land use, transportation, and other things. We do a lot of advocacy, and we think that's an important part of advancing equity, especially through this initiative we have called Public Health Awakened. We're mobilizing the public health community to contribute its power, its knowledge, its skills, its resources to engage social justice movements with the goal of advancing health equity. And in particular around relevant to this, we do a lot of capacity building. We provide training and technical assistance and leadership development to build the capacity of public agencies and in particular local health departments to take action on the social determinants of health and equity. As part of that capacity building work, we developed something called the Health Equity Guide, healthequityguide.org, which is a set of strategic practices that local health departments can use to advance equity, and case studies showing how other health departments have done so. And so I'll refer back to the Health Equity Guide in answering some of the other questions, I have a feeling. So thanks again.
Wonderful. Thank you. Mary?
Hi, everyone. Happy to be here, and thanks to ChangeLab for convening this discussion this morning. My name is Mary Lee, and I'm Deputy Director of PolicyLink. PolicyLink is a national organization, and our focus is on research and action that would advance racial and economic equity. We've been around about not quite 20 years now. 1999 is when the organization founded. Our focus is really to connect people on the ground to creating communities of opportunity that are sustainable, that allow everyone to participate and prosper. We are guided by the belief that the people that are closest to the challenges that this nation is confronting are the ones that are central to finding the solutions for those challenges. We rely on the wisdom, the voice, and the experience of local residents and organizations. We believe that local leaders are national leaders. And our work is really grounded in equity, just and fair inclusion, and we believe that that must drive all policy decisions. I have to say that for PolicyLink, the focus on racial equity has become even more urgent and dramatic. We know there's tremendous demographic shifts occurring in the nation. California is already a majority people of color state, and by 2044, the rest of the nation will also have a majority of people of color. I also think we have to be extraordinarily aware that we're operating in the shadow of the 50th anniversary of so many civil rights efforts which have gone unfulfilled. We recognize certainly that racism is actually like a cancer. It morphs into other forms when you think perhaps that you've addressed it or solved it, particularly when you have a society that is really failing to admit or acknowledge the extent and the impact of and danger and risk of racism. Our view is that race is at the center. If you don't address it, you really cannot achieve equity. That said, PolicyLink is not specifically a health organization. We really believe this racial and economic equity concept transcends all aspects of our society, including health. We do address health, though, very deliberately by looking at the need to advance healthy communities of opportunity, recognizing that place matters, that where you live is a better predictor, frankly, of your health outcomes than your biology or physiology. What we need are communities where the quality of life is enhanced and where every neighborhood has access to all of the fundamental elements of what health means, and that would include the built environment and water and air, and access to healthy food, and the ability to have decent quality, affordable housing, access to transportation, connections to jobs and education. We also have spent quite some time in recent years developing a variety of tools that focus on how to connect policy change to creating healthy communities. I'm sure I'll be able to refer to some of those in the course of our conversation here today. Some recent examples have included a convening of experts across the country who aren't necessarily focused on health, but are focused on these questions of social determinants, and we brought them together to create a cadre called the Ambassadors for Health Equity, and I can talk a little bit about that. We've been looking very closely at the notion of disaggregating data, particularly racial data, so that we can get a clearer picture of how various communities of color are being impacted by health and can be, their health can be enhanced. We're about to post a toolkit on institutionalizing health equity on our website, and We recently are working to finalize a paper on health workforce issues and how that might have a multiplier effect on both creating and expanding access to health care, but also creating jobs and business opportunities for those who've been excluded from participation in the health field, so that we have a kind of a multiplier effect, a good outcome for health access for patients, as well as good jobs and good businesses for community residents. And I'll stop there.
Thanks so much, Mary. Sarah, you want to introduce yourself?
Yeah, thank you. And thanks for all of you on the phone here, or on the webinar today. I'm the Executive Director of the California PanEthnic Health Network, CPEN. We were founded in 1992, and it was during a time much like today where there was a lot of racial divisiveness. And also on the forefront of the national agenda was healthcare reform. And so we were founded by 4 racial and ethnic leaders coming from the major racial and ethnic populations of the time, who really felt like they were being pitted against each other, and also felt like they had more in common and would be stronger together. And so the leaders came together to found CPEN in order to provide a unified agenda on health reform and healthcare issues impacting communities of color. It was at a time when California was very quickly becoming a majority communities of color state, and so they had this vision of making sure that we had alignment around particular issues. And so out of that has grown our work, which focuses on 4 major strategies: policy and advocacy, research and data, communications, and network building. And so we'll just talk a little bit about kind of each of those strategies. So under our policy and advocacy strategy, we work on legislation and administration on many different issues that really span the spectrum of health. So we're looking at community health, or those factors that create neighborhoods and influence neighborhoods, all the way up to making sure that communities of color have access to equitable, culturally, and linguistically competent healthcare services. Under research and data, that is really what we feel like fuels a lot of the work behind our policy issues. So it helps to identify where are those health disparities and how can we target resources. How can we use that information to turn it into communications tools such as fact sheets, reports, social media, and storytelling in order to help policymakers and the general public understand what health disparities and health inequities are in order to achieve a more equitable society. And then last is network building. So as I mentioned, CPEN was founded from 4 racial and ethnic organizations that became one, and since that time we've grown that network to include over 35 local-based community organizations up and down the state that represent and serve diverse communities of color. So part of CPEN's role is to help connect across communities, across regions, and to decision makers at the local and state level to impact change. Some of the major issues that we've focused on are looking at, again, improving access to health care. That was part of our founding mission, and it continues to be a major issue for communities of color across the state. So we're broadening that definition of what health care is to include oral health, mental health, as well as primary care. We've also looked at ensuring that our healthcare systems are more culturally and linguistically competent. And we've had some major legislative wins on, for example, requiring that in private healthcare systems we have interpreter and translation services available in healthcare settings. We also push state and local agencies to really improve their data collection and analysis and reporting of racial and ethnic disparities as well, including not just amongst race and ethnicity, but also language, SOGI, and disability and age. And then finally, we've really been looking at that community health factor. So how can we look at and address the issues that are contributing to health disparities in order to prevent them from the very beginning. So looking at the factors around air quality, housing, jobs, and other of those kinds of major issues that, again, we feel like could help prevent disparities from the beginning. So hopefully we'll have a chance to talk about some of those policy issues as we continue our conversation today.
Absolutely. Thank you all so much for those introductions. So let's transition straight into Q&A. I always like to start off with just getting on the same page and really spending at least just a little time on the question that so often is our starting point, which is, what does health equity mean to your organization? And if I were to drill down a little bit further, I would return to Mary's point about what is the role of health equity in addressing racism and how does that wrap into the picture. In Tuesday's webinar, Javon Muhammad joined us from the Marin City Health and Wellness Center, and she did an incredible job of historicizing the layers of policy and systems that have cumulatively overlapped to produce some powerful trauma and powerful resilience among generations of Black folks who have lived in the United States. So can you all, before we dive into some of the more detailed questions, just sketch out what does health equity mean for your organization and how does that connect to addressing racism?
I don't know if anyone wants to dictate an order, but I guess I'll take a shot at it. This is Mary.
Take it away, Mary.
Okay. For PolicyLink, I would be surprised if our organizations don't have a similar way of looking at the definition of health equity. I think it's the notion first of broadening what we consider health to be the overall quality of life. And to do, you can talk about someone's access to a doctor, and you can talk about how, how healthy someone is in terms of whether they have an illness or a disease. But these overarching questions of health, meaning the question of how people are living, how long they live, the absence of fear over whether they're going to be able to have assistance if they need it to deal with a health challenge. These are really connected to these questions of the socioeconomic factors in their communities, and those would be the same ones we deal with in every context: education, income, wealth inequality, access to transportation, healthy food, to parks and open space, to I talked about income, but specifically wages and jobs that have a career path that provide people with an opportunity, frankly, to be their best selves. And that means that you have to be able to confront the racial and social inequality and inequity that frankly have been pervasive in this nation since it was founded. And so I think it's impossible to discuss health in this nation without having a frank and candid conversation about race. And unfortunately, because we fail to do that, we don't see the strategies that are often put forth by individuals or organizations really having long-term effectiveness. In my view, all of them would work. They would all work: transit-oriented development and more affordable housing and parks and open space. But if we can't get at these questions of how we fundamentally treat each other and devise and distribute power and access to people based on their skin color, based on the place that they were born, what we'll see is that folks will just be shuffled around from place to place. We'll see people displaced, as we are right now. Gentrification displacement is really rampant across the nation. And this isn't the first time that this has happened. It's very cyclical because we haven't addressed these fundamental questions of racism and how it's shaped every aspect of our society.
Yeah, this is Sarah, and I would just echo, I think everything that Mary said is exactly our viewpoint as well. I think to kind of the way that we sort of boil it down is that, health equity is really about shifting the systems and the resources, the power and the leadership and the access and the quality of, how we're providing services, how we're looking at the services and the access that our communities have. And I think looking at it from that systems perspective, we're not necessarily, it's important to identify what the individual person or the individual family is facing on a day-to-day basis. But health equity is really looking a lot more broadly to identify what are those systems changes that need to be impacted in order for us to ensure that everyone has that access to care or the access to transportation, the access to jobs. And then I think the other aspect of health equity for us is really making sure that the communities themselves are the ones that are in those places of power, in those places of leadership, to also direct and elevate their experiences to inform the policies and the systems that are going forward.
I totally agree, and I want to build off of a couple things you guys just said, and mostly around the last piece you just said around power, Sarah. When we think about health equity, we obviously go to the same place we just heard about in terms of social determinants of health. So whether people have jobs that pay well, education, housing. But if we actually want to achieve health equity, we actually need to ask ourselves, well, why are there inequities then in jobs and education and in housing? And for us, that comes down to the answer to that comes down to power imbalances, and that's one of the underlying ideas behind this health equity guide that I mentioned. Power imbalances, people who have power actually benefit from the way things are. A housing developer doesn't want to be building more affordable housing or doesn't want more housing inspections. You could take every one of these issues and figure out who actually has power and why the status quo really supports them. Right? And so in order to address health inequities, we actually have to address those power imbalances. And those power imbalances, to go back to the question about racism, are held up by racism and other forms of oppression. People use racism and all these other forms of oppression to intentionally divide communities and to keep their own power, to build their own power. So if we really want to advance health equity, we really need to address power and oppression, and that's a fundamental underlying piece of this kind of work.
Thank you, everyone. So I think that's a really helpful framing for our discussion now. And I think a good follow-up question, and one we receive a lot, is once you agree on what health equity is, how do you measure it, right? So if indeed we're talking about health outcomes and power shifting, those are pretty heady things. And what are some tools that you all in your work and your organizations use to measure and evaluate if indeed we are moving towards health equity and a more just society?
So it's really, I think it is very hard to measure sort of like the systems change issues because there's a lot of different factors that go into changing a system, right? And I mean, some of the ways that we are looking at it is, what are the policy wins that we've been able to achieve? So there's legislative victories, for example, which are pretty easy to achieve. Either you pass something or you don't pass something. Maybe it takes you 1 year, maybe it takes you 10 years. So those are some factors. Then it gets a little bit more difficult to start talking about, administrative agencies. So, there was a question I think that came up of like, what's the role of local government to push forward or move forward health equity if we don't vote on anything? Well, you implement a lot of programs and you run a lot of programs at the local level. There's a lot of resources that go to local governments. And so part of the metrics in that also has to be, who are the people that we're serving? Who are the eligible people that we could be serving but we're not serving? And how are we making those issues or that information readily available to people maybe who speak different languages, or maybe there's particular populations that are eligible? So equity is also understanding, kind of who do we want to serve? Who are the folks? That's why the data and research piece that Mary and I talked about are super important, because you have to really understand who are the communities that we want to serve? Where are there the most disparities or issues? And then we can think about how would we, over time, what are some of the things that might be able to help reduce some of those disparities? And so, I'll take healthcare as an example because that's an area that we work in, diabetes, for example. So part of what we're asking health insurance companies to do, and in the local mental health space, we're asking local mental health organizations and providers to do, is to really understand where are those disparities, who are those communities that are not being served that are eligible to be served, and how can you target resources, whether it be outreach and materials, whether it be looking at the workforce that is going to be able to help them a little bit more, or be more reflective of the communities that they're serving. So that's kind of an example of both on the legislative side, but then also on the administrative side, kind of how we work with local and state governments to better understand how they're using their resources that could help address disparities.
So I'll build off of that. You want to go ahead?
No, go ahead, Jonathan.
Okay.
No, you go ahead.
Okay, thanks. Yeah, so we think about it similarly. I'll just more specifically, in some cases, there are clear inequities in health outcomes. So, cancer rates in the African American population, or birth outcomes. So there are clear measures of those. The work we do, like I think much of the work that PolicyLink does and the CPEN does, is upstream of that, though. And when we think about social determinants of health, so we also need to think about outcomes in housing and in criminal justice and in all these other issues, education. So part of health equity is also measuring whether we have equitable education systems and outcomes, and across those other places. And then pushing it further upstream again, it's like I was mentioning, it's for us it's about power. And so there's this question of, do we have systems, decision-making systems, and elected officials and systems that are also equitable? Are our elected officials, do they truly represent the variety of people that we have, and are they do community organizing groups have power to influence elected officials, as opposed to businesses having that kind of power, and only businesses having that kind of power? So there are ways to measure power and representation as well that I think are an important part of measuring health equity outcomes.
Yeah, if I could also encourage people to really take the long and analytical view on this question. We are confronting too frequently some funders, some government actors, and frankly even the media, who want to see measurements that are rapid. We put a grocery store in a community. Why is the body mass index of the surrounding neighborhood residents still high? Why don't we see instantaneous results from a particular achievement or accomplishment? And I respond to that by saying that we've had 300 plus years, by some analysis more like 600 years, of entrenched, racialized, systemic, institutionalized racism, oppression, divisions between people of color and whites, between immigrants, between native and tribal communities in this country. And you don't come off of that overnight, and you certainly don't shift power without a demand, without concerted and long-standing effort and involvement. That doesn't always fit neatly into a grant proposal, but it's true. And having said that, I think that yes, we can look to some of the indicators of crime rates or resources invested, or how many people have been hired, how many people have seen rates of cancer or diabetes or heart disease go down. All of those things are the kind of indicators that are often looked to for measurement, and they are valid. But I think when it comes to questions like power shifting, we need to look at how engaged and involved in leadership and decision making are the people that have been impacted by the problem or by the challenge. And to do that, you can't just assume that because we're promoting a good project or a good program, we want to get everybody to get behind putting a stoplight up or opening a park in a neighborhood that had a vacant lot that could be converted into something functional. But who was involved in that, and who was leading it, and who was advocating for it, and are the community residents formulating what the priorities ought to be and then following those priorities through? That's the beginning of shifting power, and not just on the political side. It is also, I think Jonathan was mentioning this or relating to this too, it's also who owns the businesses, who's working in those businesses, and how are they engaged and responsive, and can we see the local residents who've been marginalized beginning to be the business owners. And so that means that a health outcome is actually small business ownership, or a health outcome is somebody serving on a local board or commission or getting elected to local office. And there are activities and examples of community-based efforts to enhance the capacity of folks to do just that, to become business owners, to become entrepreneurs, to take the small business that they might be running in a small way and grow it. And that becomes a health strategy, as does grooming people to serve on boards and commissions or run for elected office, and that becomes a health outcome. And I think so does participation in local systems. So even sometimes when you lose the issue before the, let's just say, a planning commission where you're trying to get resources to clean that vacant lot and turn it into a park, maybe you lose that issue at the city council level, but if you had a cadre of active and engaged community residents, maybe you won, because maybe now there's a larger base of people who know what the systems are speaking truth to power, are ready to be and capable of being, and maybe already always were, but are now more positioned to be engaged in that political process.
Thank you for those insights. And I think it's interesting that we talk about health, and that often leads us to conversations about power and who has it and how that influences our everyday opportunities to thrive. And to me, and I know for a lot of us, power really speaks to what is the role of government in healthy change making. Sarah, you spoke to that a little bit, and some of the questions we received really centered around the potential of government and also some of its constraints. So for example, we were hearing about constraints of lower levels of government in having higher levels of government say that they can or can't produce certain policies. We have constraints from non-lawmaking bodies of government, like agencies and health departments, not being able to actually pass the laws that are so impactful on people's lives. So both in terms of framing and just very practically speaking, I'd love for you all to speak to what you see as the future of government and the role of government in promoting and protecting health equity.
Maybe I can start. So I think it's a hugely important question, and I feel like the right has done an incredibly great job of saying we don't need government, and I couldn't disagree more. And government and you know the policies it pushes are really fundamental to who we are as a society and our social compact, and it just hasn't been working for so many people. The strategy that we're pushing and we're talking about is, or the way we described it is, it's an inside-outside strategy for people who work in government. And what we mean by that is, on the inside, people in government have an inside track on things. They have access to decision makers. They have people in health departments have access to people who work in other government agencies. And so, in particular, local health departments need to use that inside power that they have. So they need to get their own houses aligned. They need to do trainings for staff. They need to make sure that the research they're doing is really focused on addressing inequity. They need to build their own leadership to do this. Then they need to partner through things like health and all policies with other government agencies and really start proselytizing and converting them so that they're focused on the same kind of equity issues and they have the same kind of analysis. That's the inside track. We work really closely with a lot of community organizing groups, which I've already mentioned. And so when we think about community organizing groups, it's not just any community organization or community-based organization. We're thinking about groups that have a base. They're grassroots groups that do leadership development with their base, and that then focus on issues that their base cares about, trying to make change that benefits the everyday lives of people who are members of those organizations. And so on the outside, we think government agencies and local health departments need to be partnering very closely with community organizing groups who can essentially democratize the way decisions are made. And there are a lot of things that local health departments can do to support community organizing and building power through the everyday activities that they're supposed to be doing, like research, for example. So this inside-outside strategy is, we feel, fundamental to what local health departments and people in government can do. They're never going to be able to change things on their own. They need that outside pressure. They need the demand, as Mary said, from externally to really be able to push things.
I just want to echo what Jonathan said about the inside-outside strategy. It's one of the ways in which we've had a lot of successes at the state and the local level. And a big component of that is actually also building relationships with community. So from a county perspective or from a local government perspective, you have to think, a lot of the services that local governments are providing, they span so many different areas, right? And so there might be many different ways in which people interact with the community. It could be through applications for funding. It's definitely on the implementation of programs and services. It could be having a complaint line, making sure that that complaint line is available in other languages so that communities who don't speak English can be able to call and engage. A big component of this really focuses around relationships. So if we have to find ways to build relationships with each other so that the door is open and that people understand. We can kind of start that engagement process around educating people what are the challenges that they're facing, and then identifying what are some of the solutions that we can work on together. And sometimes you can't work on solutions together, right? And so sometimes you need to have that tension of there's an organization or two who have those relationships and who can utilize those relationships to work on the inside strategy, who know the ins and outs of the implementation of a program. And then on the outside, you have an organized group of individuals or community members who maybe are holding press releases or press conferences to bring that awareness and transparency. So that could be a part of the inside-outside strategy. And I think, again, just to highlight that I think relationship building is really important and that sometimes education is also really important. So what could be really seen as this sort of benign practice, like, oh, we're just making this application process for, open for everyone, and it's a 10-page application process. But really what it requires is a lot of technical information and advice that may not be really open for a community-based organization to apply to if they don't really understand what are the technical aspects of the application. So again, there are these kind of benign policies and procedures that I think if counties were able to educate themselves and have an understanding or work with other experts in this area to analyze some of those practices to better understand how it may be shutting the door for community members.
I want to add to that when you think about the role of government, it is important to make some distinctions first between the various branches, the federal government and its role in health and all of these issues we've been talking about in terms of social determinants, so a massive role in education and in criminal justice and et cetera. But there's also the state and then regional, local, county and city and municipal governments. And on the latter, the local and county and regional governments, I do think we have, all three of our organizations certainly and other organizations as well, have been hearing a lot about the role that county governments, county health departments, or local health departments, are not always counties, are playing, as well as the role that other local governments are playing on these other social determinants of health issues. So if we focus on that for a minute, it's a really crucial and central aspect of what the quality of life in neighborhoods are like. A lot of these decisions happen at the local level. But there's a spectrum out there. There are health departments, government agencies, in fact, whole cities that are increasingly, maybe that's too generous, there are several that are really looking carefully and moving aggressively to want to understand what health equity is about. And they're using that terminology, and they're talking to each other, and they're beginning to build some momentum, and they're talking to several of us and several other folks out there, I think, that are listening, might have good relationships and rapport, as Sarah just indicated, building networks and communications with their local electeds and with the agencies that are operating in their counties and their jurisdictions. That said, it could be very different. There are other places in the country where it is an antagonistic and adversarial relationship between health departments or between city departments and agencies and the communities that are being most challenged and most harmed by the depth of health disparities and inequities. So I don't think there's a one-size-fits-all. I do think an inside-outside game is an important thing to do, but I think that some of us have the luxury of having more progressive, more enlightened, more aware, either staff or appointed officials who are open to and wanting to advance the notion of health equity. I'm in Los Angeles, and we have not a perfect health department by any stretch of the imagination, but they are aggressively taking on the terminology of health equity. It's on the sides of buses about what it takes to have a healthy community, and they're talking about the social determinants of health, and they've gotten quite involved, engaged in figuring out what role the health department and its various staff members can take and how they utilize their resources and how they do procurement and things like that. But I know there are many places in California and many places throughout the country where that's very hard to. That's the last thing. We're very far away from that conversation in other parts of the country and of the state. In that case, I think it's really urgently important for advocates and activists to look at how to reframe the conversations and put these questions, on the line, to really call the question of how the health departments or public agencies' roles are not resolving the health crises that they're experiencing in their communities, but are making it worse. And these are difficult and contentious places to be, but it means engaging in the media, engaging with public action, doing the kind of community organizing that Jonathan mentioned, to put these questions to the public's consideration and have people begin to use their political power and their political voice to say, we want some change. And I do think that's beginning to happen even in places that have been extremely isolated or operating in the shadows. I'm thinking of what's happened in Ferguson, for example, with at the same time that there were police murdering community residents, the question of how community residents were being fined for actions that, through the criminal justice system, and these fines were excessive for loitering, for jaywalking, for public assembly, and then those fines have fees associated with them, and so you see the city balancing its budget on the backs of very low-income people. And that information had to get out. That information had to get before the public. So that's what I mean. You sometimes need to create a platform to change the narrative and call into question these really oppressive practices.
Thanks to you all for those responses. In our last 10-15 minutes before we wrap up, I would love to hear some reflections on what you all think are really promising policy or practice that's moving us in the right direction towards health equity. I think the magnitude of the challenge and the multi-sector collaboration that is necessary is very apparent. And I know that a lot of folks are hungry for some takeaways of where some of the promising rays of light are shining. So promising health equity policies or practices that you are seeing in your work in our last couple minutes.
This is Sarah. I can start really quickly. So I think I'll outline 5 really quickly, and they'll be really quick. So one, I do think that this movement towards looking at the intersection of health and housing has been great. And so through the Medi-Cal program, there is a waiver that has permitted certain counties to really focus on populations or people that have very complex needs, and there's just a huge intersection between people's status of health and housing. And so there have been some efforts to kind of start to break down that government siloed funding to look at what are the ways that we can utilize either revenues from the healthcare system to kind of go towards housing and taking care of those who need care the most. And so I think the movement around health and housing has been, it's small, it's still in its incubation phase, but I think that's a very promising practice. I would also say the link around criminal justice and mental health I think are also really key. And so in particular, we just finished a very long process of the California Reducing Disparities Project. It was the strategic plan for reducing mental health. And while it took a really long time for this report to get out, we had engaged 5 particular populations, so African American, Native American, API, Asian Pacific Islander, Native American, Latino, and the LGBTQ population. Each of those there were 5 organizations that worked directly with community-based organizations and community members themselves through surveys, through conversations, through studying how community is providing care to each other. And developed a cross-section of different recommendations for how we can really elevate mental health as being a much more everyday part of our practice. And a lot of those focused on things like how do we look at schools and mental health and criminal justice and mental health and housing and mental health. So I encourage folks to take a look at that report because I think it is a community-driven report that took a long time to come out because I think the state of California was a little bit hesitant to endorse something like that, but it is now out and available. And then the last thing that I would say too is I think more and more that certain agencies and departments within the state of California, and I think at the local level too, are struggling with, but I think trying to figure out what are some ways that we can get funding out to sort of non-traditionally funded organizations and programs. So I know the Strategic Growth Council for the state of California has provided TA, technical assistance, to organizations to be able to have, again, focusing on those community-driven strategies that are working to reduce greenhouse gas emissions, to train people to, work in the workforce, to provide mental health services. It's still evolving. There are still some challenges, and it's still not always getting out to the community organizations that we'd hope to, but I think there's definitely there's an understanding now about what are some of the needs and challenges to getting that funding to our communities. So I'll stop there.
Thank you so much, Sarah. Jonathan, Mary, other thoughts you want to leave folks with about promising policies or practices?
You want me to go or you want to
go? You can go.
Okay, all right. So kind of different answers for this. Picking up on some of the what Sarah started around criminal justice. In general, we've moved into this place, and I guess we've been in this for a long time, of really prioritizing punishment as a solution to many things, whether it's criminal justice, it's school to prison pipeline, immigration policy, and I think that health and health equity and public health in particular has a role in changing that mindset. And so we are also doing work around criminal justice reform, sentencing reform as a public health issue, education in prisons. We've looked at a number of different places within the criminal justice system, from start to people getting involved at the beginning to reentry on the back end. all of those are health issues, and health needs to kind of take over some of that. And we're starting to see health departments and others in health engage in those things, and also on immigration policy and advocating for sanctuary cities. Those are health issues as well, and it's great to see the public health community starting to mobilize on these issues, not everywhere, but in many places. So that's one aspect I want to talk about. Second, going back to community organizing as a practice, we are seeing public health departments and others in public health starting to partner closely with community organizing groups. As Mary said, that's not everywhere. LA is particularly a great example of that. But here in Oakland, in Minnesota, in Kansas City, not your run-of-the-mill average places, health departments are partnering with community organizing groups, and they're through that with their members who are facing inequities and elevating their voice, providing them tools and helping them build their own power. And those kinds of collaborations are amazing, and I think we need to see a lot more of them as a practice. And then the last practice I'll lift up is around narrative change. And I think, again, Mary referred to narrative in answering another question. The narrative in this country around what is health and the fact that it's so much about biomedical research and personal responsibility is problematic. The narrative around what is the role of government and what's government good for is problematic. Around taxes, around criminal justice, all of these narratives that we're telling ourselves that are the dominant stories out there are getting in the way of us being healthy and achieving health equity. And we as the public health community, I think, need to engage in trying to change those stories, to try and change those narratives, putting forth a different essentially vision for what we are as a society, who we are as a society, and the role that health plays and should play in making ourselves better. So we've seen narrative change work coming out of the Minnesota Health Department. We're doing some through Public Health Awakened and with criminal justice advocates, and we're seeing many people around the country starting to take on these issues, and I think public health needs to be an active part of those narrative change efforts. Mary, I think it's on to you.
Yeah, thank you guys, because I think you've both cited some excellent examples and points. I want to say that PolicyLink certainly is also involved in some of the criminal justice reform efforts, and definitely the question of narrative shift is urgently needed on so many of these issues specifically, and then more broadly, just the kind of society that we want, the kind of nation that we're capable of being. It is an issue of being able to put forth these other narratives. I think, we also talked earlier about just the power of stories and how it is so important for other types of views and narratives to be put forth. I also want to point to a couple of things that it's hard sometimes for me to lift up and think that there are positive shining lights or potentially positive things happening. I get a little bogged down on the extent of the problem. But I just an example of how we could do so much better. I mentioned it earlier, the notion of our health workforce as being inextricably connected to the amount of access to care and the quality of care and the cultural competency of the health care that people are receiving. And so PolicyLink is very much a fan of things that create a double or triple bottom line, that have a multiplier effect. You are able to address the issue of access to quality care, but you're also creating jobs or small business opportunities for people, and therefore addressing the question of a social determinant, this question of income and jobs. And you might, by the manner in which and the location in which you site facilities for health services, you might create an enhancement to a community that's had public and private disinvestment in the infrastructure around it. So there's usually multiple things that you can address within social determinants when you're trying to solve a problem. And so we are not yet at a place where we're seeing this occur, but I think the potential for generating a skilled workforce with career path positions in health and health-affiliated fields is there throughout the country. We're going to see the loss of a lot of current members of our healthcare system as folks retire and age out. Our population, and particularly the elderly population, is expanding, and so we're going to see need increasing. So now's the time, frankly, to jump on the notion of generating and establishing pathways to these health system positions for folks who've been disconnected and marginalized in employment generally and in education generally, so that we can both expand access to healthcare and expand quality jobs and opportunities for people to bring themselves out of these economic inequities that their communities have been facing for too long. The other example I want to cite is further along, but it's on a similar vein, and I think you're going to have a discussion later in the series that talks about food justice. So this is an example that comes out of the efforts that have been ongoing to address the question of access to healthy food. And for a food justice advocate, I think they'd tell you pretty quickly that it's more than just access. It's also the type of food, the quality of food, how close it is to you, whether it's connected to your culture and it's the kind of food that you want to eat. You get the variety of it. And it's also a question of who's producing it and where it comes from. Is it local, and who works in the related jobs in food? Here in Los Angeles, I think 1 in 7 people in LA County is in some sort of a food system job. So this is a big driver of our economic engine. But the reality is that low-income people, people of color, are congregated in those food sector jobs. They're at the bottom of the wage scale, the worst working conditions, most dangerous working conditions. And we're talking about farm workers, but we're also talking about people that are doing food production and manufacturing and things like that. So the example I want to point to are examples where people are addressing the access questions and increasing access to healthy, affordable food to populations that are either living in food deserts or food swamps where there's nothing but fast food and processed food available, bringing in fresh and healthy food, but doing it in a way that enhances and promotes existing small businesses that are often owned by people of color and low-income folks, and that are most available to those folks. So it could be corner stores or bodegas or small markets. Can we bring that healthy food into those neighborhoods, or can we do it with CSAs, community-supported agriculture? The answer is yes, we can, but the multiplier impact is to say that the people that are engaged in providing the food, running the food hub, doing the food distribution are also from the marginalized communities, the underemployed communities. So there's a worker cooperative approach to owning some small distribution companies, and their target customers become these small corner stores. And we see that example percolating, and it is really exciting because we see local ownership of a business. We see increasing and enhancing and converting and upgrading a small local store, and we see healthier produce and food made available to communities that often have not had that resource available to them for a really long time. So to me that, and there are several other those kinds of examples I'm sure you'll talk about in subsequent webinars, but just to see the way that these solutions are percolating and are coming from the community residents, from the small business owners, from the workers themselves, and they're utilizing strategies like co-ops, like shared and collective food purchasing to address a problem that had been systemic, still is systemic, but they're addressing it with community-driven solutions in ways that multiply people at various places across the spectrum. So I hope we can apply that strategy to a lot of different fields. I believe that it can happen, and I believe part of the work that we have to do as we do this narrative shift is to cite examples, not to say that everybody needs the exact same thing, but that we need the same approach to how we would do this work.
Thank thank you all so much for sharing your time and your expertise and your insights. In this last minute, I wanted to just echo a couple themes I'm hearing. One is about government as a champion for health equity and reimagining the way we think about all sectors of our government. Another is bringing the voice of public health into fields where it's not typically heard very prominently. We heard about housing, we heard about criminal justice, we heard about food. And also we heard about health as both power and participation, which certainly speaks to how we might measure outcomes of health equity in terms of who has power and who has the ability to meaningfully participate in their community and their decision-making power. So with that, I thank you all so much for your time and your participation, and our audience for sharing your questions. I invite you all to join us for episode 2, which is rolling out next week. It's all about supporting working families. And if you'd like more information, go check out the URL you see on the screen here. We'll also be rolling out our blueprint for collective action, as well as our guide for equitable enforcement, and a number of other subject matter specific resources. So with that, I invite you all to keep the conversation going. Our contact information is listed on this screen. If you had questions that are just coming up now, if you have specific folks you want to follow up with, please do reach out. We're very interested in advancing this conversation of health equity. With that, I thank you all so much and hope to see you next week for supporting healthy families.